two, one.
All right, everybody. So welcome to Therapy with a Video Gamer. Today we have a very special guest, Miss Amanda Partin. She is a LCSW. If you don't know what that is, look in the other videos and they'll have a whole alphabet soup of different letters and what they mean and what they should mean to you. Not super important, not the focus today, but I do want to go ahead and give her 10 seconds or more to give a little bit about herself, talk about what got her into it, maybe talk about what her primary specialties are, and just anything else she wants to mention. So the floor is yours, Ms. Partin.
Okay, 10 seconds. Wow. Okay, so I'm Amanda Partin. I'm a licensed clinical social worker here in Las Vegas, Nevada. I am currently in private practice. I also do some contract work for an agency in town and also for a Department of Corrections entity. Currently, I have put a lot of emphasis on personality disorders, but as a licensed clinical social worker, as Chris has already pointed out in other videos, we are generalists, so we can treat a variety of things, but I've just elected to just focus my practice primarily on personality disorders.
And just before we get too far into the specifics about what we're going to be talking about today, which is a special segment on borderline personality disorder, could you maybe tell our audience a little bit about why personality disorders are so much different than pretty much anything else you're going to see in mental health?
Can you be more specific with that question?
Yeah, so we know that the personality disorders are a little bit more pervasive in that they take more treatment. It's not as simple as, why don't we try these coping skills here for your depressed mood or try this medication. Oftentimes it takes both or that and more. Can you just explain how it is that personality disorders are that much more complicated to treat?
Great. Yeah, now I understand your question. So personality generally, as a broad statement, is an enduring pattern of behaviors, traits, perceptions, thought processes. It's enduring, so it's across domains and across your lifetime. It's pretty unusual that anybody would be diagnosed with any kind of personality disorder, in their teens. I think the DSM is pretty clear not to do that, but other professionals have and will, because there is some evidence to suggest that you can show symptoms of pathological personality disorder traits very early on in life, like preteen era times. So that's one reason. The other reason is because it's across domains. It's a person who might have depression, it's kind of one issue. It can be pervasive as well, but it's episodic in nature generally, unless we're talking about like dysthymia or something like that. So you can increase some serotonin, do some cognitive behavioral therapy, address some distorted thinking patterns, and you really are on a good path to relief fairly quickly if everyone's engaged and there's some compliance and true motivation to change. Personality disorder is different because there isn't super great evidence to suggest that medication's helpful.
Sounds like it's a lot more complicated than what you would typically expect in a therapy office. So you might need a little bit more specialized training, or you might need someone who has taken the time to understand that diagnosis and the population that experiences it than just what you would take away from grad school or something like that.
100%. So if someone who just got their CPC or their internship license,
whatever their alphabet soup is.
Yeah. So whoever is just out of graduate school or even higher level than that, you could have a doctorate degree as well. Generally speaking, this is a very broad statement, but clinicians, therapists aren't taught about personality pathology. I'm sure everyone had to take a DSM class. You have to kind of know and recognize some basic symptoms, but it's often the case that you're not really educated very, very much about personality disorders or their treatment. And it's my opinion that the reason is linked to financial reasons. Insurance agents or insurance companies typically don't pay for access to, which is old terminology, but personality disorder treatment. So if your primary diagnosis is that in the personality disorder, it's possible, and I would say probable, that your insurance company might not reimburse.
Why don't we just go ahead and define what we would even be looking for, or what someone who lives with borderline personality disorder, what exactly would they be experiencing?
Yeah, good question. So, borderline personality disorder is the DSM has it defined as a pervasive collection of symptoms. It might impact your romantic life, your friendships, your employment, school, all across the domains of life. And there are symptoms that can kind of be clustered around interpersonal issues, poor and changing self-image, marked impulsivity, this idea of having poor relationships where you pull people in and then may push people away. Self-harming is kind of a big one. Not every person who has borderline personality disorder is going to self-harm, but it is a feature in the diagnostic criteria.
Could you tell me a little bit about what your approach to treating this particular issue is?
So transference focused psychotherapy is a treatment that really hones in on the relationship between the therapist and the client. So in the treatment room, or in the Zoom room as it is in 2020, very strange. It's boundary focused. We have a frame that we work in. So it kind of protects the therapy. We identify early on what are the barriers to you getting good treatment. How will this dynamic that we have, or this treatment relationship that we have, implode? And we safeguard right away for those pitfalls, as it were. And we focus on the defense mechanisms in the session, outside of the session, that the client brings in. And we identify kind of our own feelings, not in the therapy, but in our supervision. We use our own experience and our own sense, intuition, to help inform us of what could be going on in the psyche of our clients. We have three main approaches to how we help our clients. We clarify. We do not claim to know and fully understand the lives or experiences of our clients. We really clarify. We ask and ask. We really want to know and almost step into the world with you. We want to look through your eyes to really get a sense of, what's going on, how your thinking is, how your feeling is in these moments. So we clarify. We also offer interpretation. So that would be like, hey, look what you're doing here. You're treating me horribly. Is it because I'm reminding you of, your boss? Are you treating me like your boss? And that could not be the case. The client could say, no. And then we would move on. So that would be probably a very poor example of interpretation. And the last one is confrontation. And confrontation is also like a 4-letter word in therapy. Like, you can't say confrontation. You can't be, you've got to be warm and loving and supportive. But confrontation actually just means you said this, but you're doing this. And a perfect example would be, you're smiling while you're talking about overdosing on pills because your boyfriend was threatening you. I'm confused. I would be asking the client to make sense of that. How do you understand what's going on there?
And maybe that's the first time they've even considered something like that. Like, oh, that doesn't make any sense at all.
Absolutely. Maybe that's the first time they even have an inkling of insight about how they're smiling, saying something kind of horrible. DBT is group. It's a group component and a one-on-one component. DBT, to my understanding, so I don't practice DBT, so this is very off the cuff. I'm by no means an expert in dialectical behavioral therapy, but my understanding is it's the foundation is cognitive behavioral therapy, thoughts, behaviors. But DBT focuses primarily on skill building, helping people who have suicidal ideation, but it's supposed to be like skill building. So essentially, if X, then Y. So if having suicidal thought apply coping skills. There are very few people that are certified to do DBT. Plenty of people know some basics and they can be helpful, but in terms of like going through the process, very, very few people have that here in our neck of the woods.
Right. And I think I remember hearing that from a professor in grad school, that she wouldn't even, with all of her years of seasoned clinical work and everything, she still wouldn't be comfortable saying that she is a DBT therapist, but she's DBT informed and she's very eclectic in a lot of her practice, which I think is kind of the common denominator in this area.
Yeah, yeah.
The causes of borderline personality disorder are believed to consist of multiple factors, including genetics, environmental factors, individual neurodiversity. So in your own experience, what are common and consistent factors that have contributed to someone who has a diagnosis of borderline personality disorder?
That is such a tough question because the reality is we don't know. There's some evidence to suggest trauma is a big one. And I think broadly we could say that, but we can't say trauma equals BPD, nor could we say everyone who has trauma develops BPD, or BPD is only a function of trauma. You could have no trauma and still have BPD. But it's my opinion that trauma significantly leads to this trajectory.
Mm-hmm. Well, and when I think of trauma, I think of the shame that usually underlies whatever that trauma is. And shame is like the ultimate disconnect of connection, which is what we need to survive as human beings. So just kind of by all that logic, it would make complete sense to me that there is a strong link to trauma. Does also account for a lot of the language we're hearing, I think, today about having a trauma-focused practice or a trauma-informed lens, so to speak, so that you look at the problem and look for explanations and not so much like slapping their hand and why did you do that?
Mm-hmm. Yeah, understanding, clarifying, their ideas, their history, etc. Yeah.
The diagnosis of borderline personality disorder is very stigmatized. Like it's very easy for people to get that diagnosis and feel like there isn't a whole lot of hope for them moving forward because it's a personality disorder to begin with, and those are really, like we've talked about before, difficult to make significant progress on to where it sticks. Would you say because of that there is often a much higher like misdiagnosis of borderline personality disorder, maybe for clients that initially clinicians might find like, oh, this one's just too hard, or I don't want to see this person in my office again, so I'm going to give them a diagnosis that they don't really have so that they leave my door?
That is such a good question. I actually think it's the opposite to some extent. I think people present with symptoms of BPD and the clinician either lacks the training to really accurately assess and say, hey, I think this is what we're working with. This is what we need to address. And they might get diagnosed with bipolar disorder. That's frequently misdiagnosed. You can have both, but oftentimes you have bipolar disorder, you need to go see a psychiatrist, and you can already see where this is going. If you go to the psychiatrist, that's not going to be helpful for BPD. So that's a misdiagnosis if it is genuinely not the case that they have bipolar. But yeah, I think actually oftentimes people are misdiagnosed. I do think it is the case, sure, that sometimes people are arbitrarily diagnosed, for whatever reason. Clinician bias is certainly one of them. But, I underscore that by saying if you are using insurance, that's not going to be your primary diagnosis. And therefore, there might be a lack of motivation to really assess or treat personality. So insurance generally says you need to do an assessment and we need a diagnosis that we'll pay for, which again, might not be a personality disorder. There's plenty of people out there that believe that once you have a personality disorder, you don't get better, which is why insurance will not pay for it. If the prognosis is bleak, well, why would we throw money down a hole? This person's never going to recover. That's absolutely not true. So why, it goes back, in my opinion, just to stigma. Many clinicians don't treat it. So it's quite difficult, depending on where you are in the world, in the nation. It's quite difficult to find treatment for personality disorders. So that's another barrier to good treatment.
If they are consistently being told either in their explanation of benefits or maybe directly by some insurance rep, like, oh no, we don't cover that. It's great that your therapist made that diagnosis for you and that it's clinically accurate, but good luck, we're not going to pay for it. It's probably pretty discouraging to a lot of people who are living with that. Insurance isn't the most attractive option for me in terms of payment, and I'm pretty upfront about that just because they are pretty long with their payout schedule. My idea of when I should be paid and their idea of when they should be paid is usually very different.
Sure.
And it's discouraging even then, I think, for people to try and access their care that way if it's even harder to find providers that will be in their network and that can give them the correct diagnosis and recommend the right treatment. Like, hey, you need to go to 3 groups a week on doing equine therapy, and that's just what is ultimately going to be the very best thing. Well, good luck. I hope you got some money for it.
Absolutely.
It's also arbitrary, it sounds like, 9 weeks, 12 weeks, 24 weeks. Like, who comes up with these numbers? Probably insurance. Who comes up with these numbers and how do they come up with them? Who are they to say that it's only this many sessions that are really necessary for you to get better? And if not, then I guess you weren't trying hard enough or something like that.
Yeah. And at that point, maybe your insurance is, fully within their rights to say, you've exhausted your mental health benefits. Now you need to be on medication. That is the next logical course. You've exhausted this, go see a psychiatrist. Of course, as a client, you do have the right to say no, but in terms of your insurance reimbursing, that's a different situation. They have the right to say no as well.
If you suspect that you may be experiencing symptoms of borderline personality disorder, what might be your first step to addressing it?
The first step to addressing any sort of symptoms of any mental health condition would be to start to find a therapist. You need to have a good assessment. If you really maybe you've been diagnosed with BPD in the past, or somebody along the way has indicated to you, you have these symptoms or these traits, I would really recommend that you look for a therapist, regardless of the alphabet soup out there, some sort of credentialed therapist that explicitly says that they're interested in treating people who have borderline personality or personality disorders in general. I would also recommend that you look specifically for a therapist that says, hey, I'm DBT informed, or I'm DBT certified, or I use MBT, or I use the approach that I'm training in and I'm informed by is called transference focused therapy. So those 3 would be kind of right out of the gate something I would recommend anybody be considering and looking at.
But a lot of people have a particularly dim view of the prognosis, like you said, about borderline personality disorder. What if you had someone who wasn't exactly enthusiastic, but they came in and it was like their life may as well be over because they're convinced that they have a personality disorder, and borderline is usually the one that I think of with that in particular. How would you instill hope?
Well, it's treatable. And that's what I say in my own practice. This is a treatable diagnosis, but it is work. This is not going to be an experience where you come into therapy session and you vent and you leave feeling so much lighter. That's not going to happen. It could happen maybe a time or 2 perhaps, but it requires work. And the approach that I use, generally speaking, what's indicated is twice a week. 50-ish minute sessions, intensive. We got a lot of work to do. We got to equip you with a lot of insight to get you moving forward. But it is treatable, but it's not going to be treated overnight. Your personality developed over a lifetime, maybe 2 years, depending on how often you could actually afford to pay for therapy, attend therapy, engage in therapy, and just other supports in your life. Maybe 2 years. Oftentimes people who have personality disorders stay in therapy for, far more than 2 years, 5 years. It takes a long time. Progress can be slow. Progress can be huge though. If someone's cutting themselves 50 times on the arm every day, and they're all hospitalized every other week, and now they only cut once a month, that's huge. But on the surface level, it's like, well, you're still cutting. Mm-hmm. Yeah, but it's a big difference.
Progress is not necessarily what people think of when they go to like a primary doctor, where you go in and you feel sick, you feel injured, you feel whatever. You want them to give you a drug or a treatment or a doctor appointment somewhere that's going to make you feel better. And it doesn't necessarily pan out that quickly when you're in a therapist office.
Absolutely not. Yeah, and that's kind of another issue. I think we're kind of taught that like good therapy is short. Therapists should really only work with clients like, I don't know, 8 to 12 weeks. But I think that's really rare that anybody gets some significant mental health treatment with 12 sessions, unless it's, kind of a really high functioning client with very, very mild symptoms.
If I have a friend or a family, say that I'm living with borderline personality disorder, mm-hmm. anyone else that's watching, listening, what would the best thing for close friends and family of mine to do to support me?
Ask how you would like to be supported. To go one step further, I think it's often the case if someone who has BPD is in treatment, which is wonderful if that's the case. If they are in treatment, any good therapist, by my measure, is really interested in, how other loved ones or even roommates or friends, whoever you live with, how you interact with them. And inviting that person in, of course, if the client's comfortable, inviting that person in could provide huge amounts of information that would be very valuable, because the client only sees the client through their own eyes. We're working in the session, but having an outside perspective say, yeah, these are the things that I notice, that could be very, very helpful to your overall treatment. Well, I don't recommend, if you're listening to this, you say, well, I'm showing up to your therapist office because your therapist needs to know these things. I don't recommend that. I think these are conversations and everyone needs to be on board and open to it.
Okay, so I think we're getting close to the end here. I want to ask one more thing. There is a lot of information available about this topic, and not all of it is accurate. Definitely. or non-judgmental.
Definitely.
So could you, if you have any prepared, do you have any reputable sources of information that either BPD providers themselves could maybe provide for clients, or if you're at home and you're looking at this stuff on your own, that you could kind of do some of your own research?
To the people at home that might think a loved one has BPD, or you yourself think you might have some symptoms, I don't recommend Googling or WebMDing. What I do, I have a little website link. It's called borderlinedisorders.com. It's really tailored to clinicians. However, there is a spot, and I could send you probably the area specifically that you could link. It really does a nice job of kind of bringing to life these symptoms that you could read and understand more fully. Does that sound like you, or not really? Mm-hmm. That would be my recommendation. And then go to see a skilled clinician. Let that clinician help guide your understanding of your symptoms and kind of what the barriers to treatment are, etc. I don't recommend you Googling too much, because as you've already pointed out, there's so much stigma. For anybody who's interested in learning more about TFP, which is the one that I'm training in at the moment, not certified, informed, as you said earlier. You can Google Otto Kernberg. He is the founder of this particular approach. Also, books by Frank Yeoman would be helpful, John Clarkin.
Okay, and I lied. I have one more bonus question. Okay. If someone right now is watching this and they are suspicious that they might be experiencing symptoms of borderline personality disorder, and they are really not sure what they should be doing next. I know you said, start looking for a therapist and talk to your family about it, but what reason, I guess, do they have to believe that things will get better? How do we know that things get better?
Well, things get better if you actually lead a measured life and really understand what's going on with your mind versus your mind controlling your life. There is a potential for you to have a really meaningful life, but it does require, your consent. It requires you actually buying into the process and trying. And the moment that you feel like even the notion of curiosity about whether or not you have some of these symptoms, that's a good sign, because it means you're not indifferent or numb to them. You're curious. And to me, that leads to a greater likelihood of a good prognosis, meaning you could recover from these personality symptoms.
All right. Well, thank you so much for giving us your time and your expertise today.
Of course.
Thank you so very much for coming on. I really appreciate your time today.
You are so welcome, Chris.
Did you like what you just saw? Make sure you like and subscribe. New videos come out every Tuesday.